Hello, I'm Dr. Sin Yun Cho from Yonsei Ivy Dental Clinic. It's a pleasure to meet you through this online surgery program. Today, I'm excited to share an endodontic case for the first time as part of the online surgery series. I plan to share a variety of informative and meaningful cases with you, including both surgical and non-surgical endodontic treatments. For our first session, I'll be presenting an apical surgery case involving a maxillary molar. The patient is a 40-year-old male. This patient presented with a persistent sinus tract on number 26, even after retreatment of the root canal. As seen on the radiograph, a small periapical lesion is present around the apices of the MB and DB roots. This tooth has a history of previous root canal retreatment. Given the condition, one treatment option could be another round of root canal retreatment. But the tooth has already undergone retreatment, and the procedure appears to have been adequate, so repeating the treatment may not be justified. The next reasonable step would be to consider apical surgery. Other options include intentional replantation or implant placement after extraction. However, among the surgical approaches, apical surgery is one of the most reliable. When properly performed, it has a success rate of over 90%. For this reason, in cases where periapical inflammation recurs after retreatment, apical surgery should be considered the first-line option. If apical surgery is not feasible, intentional replantation may be considered as an alternative. However, with maxillary first molars, the roots are often widely divergent, especially between the buccal and palatal roots. As a result, root fractures frequently occur during the extraction process. Therefore, both maxillary and mandibular first molars are not appropriate for intentional replantation. In cases like this and in most first molar cases, apical surgery should be the first-line treatment. Now, here is the cone beam CT image for this case. Before performing apical surgery, it is essential to review the internal anatomy using CBCT. Here, you can see that the root on the right side is the buccal root. This is the root we're planning to operate on. The periapical lesion appears to extend slightly toward the palatal side of the buccal root, which is clearly visible on the CBCT. It is critical to evaluate the surgical accessibility in advance, based on the CT images, before performing apical surgery. Now, since this is the buccal side, if we plan to approach from the buccal side, the apex of the buccal root does not appear to be far from the buccal bone. Additionally, the buccal bone is relatively thin, so surgical access should not be challenging. Moreover, given the presence of a sinus tract, it is likely that some degree of cortical bone erosion has already occurred. So, in this case, locating the apex is not difficult. One notable anatomical feature of maxillary molars is their close proximity to the maxillary sinus. Therefore, it is essential to assess the relationship between the root apex and the sinus prior to surgery. In this case, there appears to be a safe distance between the root apex and the sinus wall. However, the lesion seems to extend quite close to the sinus. Fortunately, on the CT scan, there is no evidence of perforation of the sinus wall. However, if any portion of the bone has resorbed to the extent that it communicates with the sinus, special care must be taken during surgery. In this case, it will be important to confirm whether a sinus perforation is present using a probe. That said, based on the CT scan, there does not appear to be any perforation, so we can conclude that this is not a high-risk case involving sinus. Now, let's move on to the surgical video. In the posterior region, it's difficult to obtain adequate visibility without a vertical incision. For that reason, I routinely make a vertical incision in these cases. In this case, since a sinus tract was present, I initiated bone removal around the tract. The goal of bone removal is to locate the root apex. Identifying the apex is essential because we need to resect 3 mm of the root tip starting from that point. Once the apex is identified, root resection is performed at a 0.3 mm from the apex. The root should be resected as perpendicular as possible to the long axis of the tooth. For the root resection, it is preferable to use a high-speed handpiece with a 45-degree angled head. Personally, I use a thin-tapered diamond burr. As you see now, the resected root tip was removed. With the surgical field now clearly exposed, thorough curettage of the granulation tissue can be performed. After debridement is completed and the area is clean, we check for any remaining unresected portions of the root, and additionally remove them if necessary. At this point, if instrumentation is limited due to the root end cavity, it is acceptable to slightly enlarge the shape or size of the cavity. Next, we inspect the resected root surface. We check for causes of failure, such as the presence of an isthmus, or any cracks in the root structure. If no significant issues are identified, we proceed with the retropreparation. Retropreparation should be performed in alignment with the long axis of the tooth. This ensures that the gutta-percha is properly removed. If the angle of preparation is off, it can lead to unnecessary removal of dentin. Therefore, in order to completely remove the gutta-percha while preserving the surrounding dentin, it is essential to align the retropreparation with the long axis of the tooth. This alignment of retropreparation must be evaluated in two planes, the mesiodistal axis and the buccolingual axis, in this case, specifically buccopalatal axis. Proper retrograde preparation should be carried out in alignment with both the mesiodistal and buccopalatal axes. That's why it is important to assess these axes in advance using cone beam CT before the surgery. In this case, we are in the process of removing gutta-percha from both the MB and DB canals. Particularly on the buccal surface of retrograde cavity, it can be quite challenging to remove the gutta-percha due to limited access. Visibility is often limited in this area, so it's important to make an effort to thoroughly clean this area. Now, the retrocavity created during retropreparation is similar in shape to a Class 1 cavity. And all the external walls of this retrocavity must be completely clean. Only then can we completely fill it with bioceramic material or MTA. So it's essential to carefully inspect to ensure that no gutta-percha remnants remain in the entire cavity wall. Apical surgery is performed under the assumption that contaminated material still remains within the tooth. Since complete removal of this material is not possible, the goal of the procedure is to seal the canal from the apex. Therefore, achieving a complete seal during this step is critical to the success of the procedure. If this sealing process is inadequate, failure is almost inevitable. That's why this stage is the most important part. In order to achieve a successful retrograde filling, the retrograde preparation must be precise. We are now inspecting the external walls to ensure that no remnants of gutta-percha are present. A smaller micromirror is used to take a second look. It provides better visibility, especially when examining the buccal wall of the cavity. After thorough inspection, we confirm that there is little gutta-percha remaining. At this point, we move on to preparing for the filling process. One of the most critical steps here is hemostasis, because bleeding must be well controlled. In this particular case, bleeding is minimal, so cotton roll packing should be sufficient and should not interfere with the filling process. Now we're almost ready to proceed, but as a final step, we're doing one last inspection. We're checking once more to make sure there's no remaining gutta-percha on the cavity walls. In particular, we're condensing to push down any remnants that might still be present along the buccal wall, just to be certain nothing is left behind. We perform one last check. We see the cavity walls are now clean. We're now ready to proceed with the retrograde filling. For this case, I used Osstem as the filling material. This is the pre-mixed syringe type, which allows for easy application. It can be just expressed into the cavity. After the initial placement, a piece of wet cotton is placed to facilitate the initial setting. After 3 minutes, you can see that the Osstem now has a slightly putty-like consistency. Since achieving a complete retrograde filling is the most critical part of apical surgery, I'm condensing the material once more to ensure that there are no voids. After the condensation is completed, I perform an additional filling of Osstem over the area. This time, I intentionally overfill it slightly. A wet cotton pellet is then applied again over the material, and we wait another 3 minutes. After 3 minutes, the wet cotton is removed, and we can see that the Osstem has a putty-like consistency. At this point, as we're approaching the end of the procedure, any excess material is removed. Once the cotton is taken out, I begin to smooth the external surface of the filling, almost like burnishing. In other words, it is an additional packing. Then, using a wet cotton pellet, I gently wipe the root surface clean. With that, the surgical procedure is complete. After completing the procedure, we conduct a final inspection to ensure that the retrograde filling is intact and that no voids are present. This step is critical, as the filling is the most important factor in the success of apical surgery. If a dental microscope is available, it's ideal to perform this check under high magnification for greater accuracy. On the postoperative radiograph, we can confirm that both the MB and DB roots have been densely and cleanly filled. Although the original lesion was not that large, we can see that it has slightly decreased in size. The tooth has been functioning well without any significant issues. Now, if we compare the two images, we can observe some radiolucency remaining after the procedure. However, at the 1-year follow-up, there is a marked reduction in that radiolucent area. The 1-year cone beam CT shows that the radiolucency has almost completely disappeared. The patient has been using the tooth without any major discomfort. That concludes today's presentation on an apical surgery case involving a maxillary first molar. Thank you for watching. I look forward to sharing more valuable cases with you in the future, including both surgical and non-surgical endodontic treatments. Thank you.